We're going to move on to the public comment session. I'd like to welcome and thank our public comment speakers for addressing the committee today. All the speakers today submitted a request in advance of the meeting, and the final list of public commenters was determined via lottery. For our speakers today, we have a limited public comment period, and in order to make it through all the listed speakers, it's extremely important that each speaker limits his, her, or their remarks to 3 minutes. We will be displaying a timer on the screen that you can see so you know how much time you have left. We appreciate diverse viewpoints that are respectful in nature and focused on the issues being discussed at the meeting, or this 3-day meeting. Thank you again to our speakers, and we look forward to your comments. And our first public comment speaker is Lindsay Clark.
Hi there, can you hear me okay?
We can. Please go ahead. Thank you.
Great, thanks. Good afternoon. Thank you to the committee for this opportunity to comment. My name is Lindsay Clark, and I'm the Senior Vice President of Health Education and Advocacy at the Alliance for Aging Research. One of the educational campaigns that I lead at the Alliance is the Our Best Shot campaign. Over the years, this campaign has produced dozens of educational resources focused on raising awareness about the importance of vaccines in older adults, how they work, which ones are recommended by this committee, how the Medicare program covers vaccines, and more. The resources have included a focus on influenza, pneumonia, shingles, and COVID. And this past year, we produced educational films on RSV in older adults, emphasizing to viewers that RSV is not just a pediatric disease. While we know that older adults are especially vulnerable to serious complications from RSV, we also know that adults ages 60 to 64 living with asthma, congestive heart failure, COPD are all at high risk for RSV-related hospitalizations and deaths. Additionally, studies from the CDC and others presented at the ResVnet conference in January demonstrate that a higher proportion of adults ages 60 to 64 who were hospitalized and or experienced severe outcomes due to RSV were Black, Hispanic, or American Indian Alaskan Native. These racial and ethnic differences are critical to consider when determining age recommendations for the new RSV vaccines. Earlier and higher rates of asthma, congestive heart failure, or COPD in communities of color due to structural racism leads to earlier RSV onset and higher risk of hospitalization and severe outcomes, including deaths, and must be considered as part of the age recommendations. Once the recommendations are determined, we urge publication in the MMWR without delay. While respiratory surges are no longer limited to the traditional cold and flu season, we know that the surges of influenza, COVID, pneumonia, and RSV and other respiratory illnesses continue to flood and overwhelm our healthcare system in the fall and winter months. Being able to start administering these vaccines for the fall season will undoubtedly save lives. Lastly, we urge the federal government to make sure that the safety of co-administering multiple vaccines like RSV and influenza, COVID, or pneumonia is clearly communicated. We know from our education and outreach that misinformation about the safety of receiving multiple vaccines at once persists, and clear communication from the FDA, CDC, and other agencies is critical in the distribution of reliable and trustworthy information on vaccination and specifically on co-administration. We are excited about the new RSV vaccines, and while general awareness and prevention will remain a priority for the Alliance, we look forward to being able to encourage older adults and all adults at high risk to receive an RSV vaccine to protect themselves and their loved ones. Thank you again for this opportunity to comment.
Thank you for your comment. Next, we have Erica DeWald.
Thank you and good afternoon. I am the Chief Communication Officer at Vaccinate Your Family, an organization you will hear about from my colleague, Cerise Murata, in just one moment. Thank you for the opportunity to comment. I wanted to thank the ACIP voting members and liaisons for all of their hard work in recent years. While many in the general public first became aware of ACIP during the pandemic, our organization has held the ACIP in the highest regard for decades. And our policies specifically stipulate that Vaccinate Your Family follow the recommendations of this committee. This week's meeting showcases the depth and the breadth of the work you do. ACIP serves a critical role in ensuring the safety and efficacy of our vaccine schedule in the U.S. As independent experts, your review of the available data presents an unbiased view of how best to protect people in this country. Science and the data it creates should always lead the way on vaccination recommendations. As you consider votes on new pneumococcal and RSV vaccines, as well as a reformulation of the COVID-19 vaccines, Vaccinate Your Family urges you to continue to consider the available data. Too often in recent years, politics have attempted to replace science. The ACIP has remained firm in their commitment to follow the data. We hope others will, in turn, continue to follow the ACIP and respect their independent review of the safety and effectiveness of new and existing vaccines. Thank you again for the opportunity to comment.
Thank you for your comment. Next, we have Cerise Marotta.
Good afternoon. Hello, I'm Cerise Murata, Director of Advocacy and Education at Vaccinate Your Family. On behalf of Vaccinate Your Family, thank you for the opportunity to comment today. Established 30 years ago, Vaccinate Your Family works to protect people of all ages from vaccine-preventable diseases through advocacy, education, and policy. As evidenced by the COVID-19 pandemic, there is still much work to do to improve health equity, and this is a priority for our organization. While we recognize that ACIP is discussing several important topics this week, my comments will focus primarily on respiratory syncytial virus, also known as RSV. Our organization is pleased that the committee will be considering recommendations for RSV vaccines for older adults, and we sincerely appreciate the robust discussions this morning. RSV infections in older adults result in 60,000 to 160,000 hospitalizations and 6,000 to 10,000 deaths every year in the United States. Recent studies found that the economic burden of RSV infections on healthcare systems was substantial, with RSV hospitalizations resulting in a national direct cost burden of $1.5 to $4.0 billion for adults greater than 60 years old. Given the public health and economic burdens of RSV on older adults in the US, it is imperative that we have preventive measures like vaccines available as early as possible to help protect older adults from this disease. RSV can also be serious for infants and young children. Every year in the US, 58,000 to 80,000 children younger than 5 years old are hospitalized with RSV, and an estimated 100 to 300 children younger than 5 lose their lives to it. RSV not only causes a significant public health burden for young children, it also creates a serious economic burden for families. According to a recent national survey, more than 2/3 of parents said that RSV caused a financial burden or crisis to their family, and RSV has disproportionate impacts on Black and Hispanic Latino infants, as well as those on Medicaid, which is why it's so important that we have equitable access to preventive measures, including tools like monoclonal antibodies and maternal vaccinations. The past 22-23 season saw a resurgence of RSV along with other diseases like respiratory diseases like flu and COVID, resulting in a triple-demic that puts serious strains on our healthcare systems. We urge ACIP to follow the science and, if possible, provide timely recommendations prior to the start of the next RSV season this fall. This means the inclusion of passive immunizations in the VFC program and the timely publication of MMRs. Thank you.
Thank you for your comment. Our next public comment speaker is Martha Nolan.
Good afternoon. My name is Martha Nolan, and I am the Senior Policy Advisor for Healthy Women, an advocacy organization committed to educating women so they can make informed health choices, advocate for themselves, and prioritize their health and wellness. For thousands of women across the country, we are a trusted source for credible, up-to-date information relevant to their mental and physical well-being, and we believe a critical aspect of this is preventive care. We understand the vital role that vaccines play in protecting against severe disease and are a strong proponent of ensuring that women and their families have the information they need to make informed decisions about their vaccine options. Last year's unexpected influx of RSV cases on top of the already active flu, COVID, and pneumonia season presented a stark reminder of why continued innovation in vaccines is so necessary. At the time, many adults were learning about the risk of RSV for older Americans for the first time, and there were no vaccines available to protect themselves. We know that, on average, as many as 160,000 adults 65 and older are hospitalized for RSV, and up to 10,000 older adults die each year from the virus. These numbers do not capture the many more Americans who may not require hospitalization but suffer at home from this illness. Given the considerable increase in respiratory threats facing the older population over these past few years, the need for preventive tools to defend against them cannot be overstated. It is also worth noting that the majority of care is provided by women, with 1 in 4 women reporting being caregivers, and over 1/3 of these women reporting that they are caring for a parent and a parent-in-law, according to the CDC. Caregiving is a challenging and demanding responsibility and involves spending an extensive amount of time with those caring for and can put older Americans at greater risk of contracting a virus like RSV. given the intergenerational aspect of a woman's caregiving roles. That is why we are so encouraged to be here today speaking about not just one, but 2 FDA-approved vaccines for this virus after decades of having no protection. This is truly an important step forward, and we are eager to share this committee's recommendations with our communities so that all those who are eligible can benefit from this critical protection. Healthy Women is grateful for this committee's work to ensure that these new protections are made available to those most vulnerable to serious illness and death. And we ask that you provide as clear and simple guidance as possible on who should consider receiving these vaccines. But as you know, that is not the final step before older Americans can access these vaccines. So in order to ensure everyone who is eligible for the needed protection has broad and equitable access to the vaccine before the start of yet another respiratory season this fall, we ask for the process for publishing this guidance to be done in a timely and straightforward manner to ensure potential timely coverage by CMS. Healthy Women appreciates the opportunity to address this important issue, and we look forward to communicating the CDC's guidance to our communities so that everyone who is eligible for the vaccines understands the value they play in protecting their long-term well-being. Thank you.
Thank you for your comment. Next, we have Dr. Michael Horger.
Thank you all for your service during this difficult time. I'm Mike Herger. I run a health science PhD program in the Deep South. I'm a clinical health psychologist, health scientist, and health strategist. I'm also in the sandwich generation with 3 young children at home and older relatives nearby. I have a few comments about COVID. We know from national wastewater data that SARS-CoV-2 transmission is lower now than during 75% of the pandemic, of course, higher than 25% of the pandemic. But during this time of lower transmission, it's important for organizations and families to hopefully catch their breath and reflect on their COVID strategy. I appreciate how receptive you all were to oral comments last time, and I have a few strategic suggestions about COVID vaccines. First, transparency. I think we need more transparency and balanced framing. We need to be clear on vaccine efficacy while also acknowledging that benefits wane substantially after 2 to 4 months, not annually. And they do less to protect against long COVID than we might hope, with cumulative risk increasing upon each reinfection. My family's highly vaccinated and we get more today if possible, but we need to avoid overpromising on any particular tool. Second, agility. We need faster COVID vaccine updates based on emerging variants, so we're skating to where the puck is going, not to where it was months ago. We need to open up Novavax to all Americans 6 months and older, regardless of vaccine history or ability to pay. We desperately need next generation vaccines that substantially reduce transmission. Third, we need a multi-layered strategy. SARS-CoV-2 viral-laden aerosol particles linger in the air like smoke, infect people when inhaled, and can cause severe damage to multiple organ systems. In addition to vaccines, we need to emphasize the use of high-quality, well-fitting masks. Some of the best N95s are now only 9 cents each and readily available. We also need to emphasize the importance of air cleaning through ventilation and filtration, particularly given the forthcoming ASHRAE building standards. Babies under 6 months cannot mask or get COVID vaccines, so we need safe spaces in healthcare and at vaccination sites. A year ago, my twins were newborns and we had to navigate through a large health system to receive recommended medical care, and we passed 70 clinicians who were unmasked. That's extremely dangerous. We need masks in health and in dental care, particularly for patients who must be unmasked at times for care. Finally, we need to do more on outreach and education. Nationally, uptake of the bivalent booster has been lower than we would hope, and particularly so in my part of the country in the Deep South, often even among older adults. We need to reach out to the community, retail pharmacy chains, and clinicians. Again, I appreciate you all working hard during the ongoing pandemic, particularly when you and your families may be dealing with illness, trauma, moral distress, bereavement, and other stressors. It's very important the work you're doing. Thank you for your time.
Thank you for your comment. Next, we have Ms. Sarah Berry.
Hello, CDC ACIP members. Thank you for your attention today. My name is Sarah Berry, also known as 42 Believer Online, and I am an independent pro-vaccine advocate who splits my time between gathering critical information on anti-vaxxers for numerous journalists and volunteering my time with pro-vaccine individuals and groups. One of them is Safe Communities Coalition, a nonprofit focused on educating legislators about vaccine policy issues, although there are many more that I like to talk to when possible. My purpose in giving a comment today is to talk about the stifling of innovation when anti-vaccine talking points embed themselves in the mainstream. We see this in low uptake for flu vaccines, which aside from the HPV vaccine, were the most commonly attacked vaccine prior to the pandemic. Some people, even those who I know personally are not anti-vaccine have hesitations about the necessity of the flu shot. So how do we reach the average person about the flu vaccine? I have one talking point I use when speaking to friends who are genuinely hesitant about the flu vaccine, which is to bring up a sadly not unheard of, but very serious consequence to flu infection: quadruple amputation. I very recently, just yesterday, had a conversation with two friends about this, and even shared pictures showing children as young as 5 needing this kind of intervention. And they were absolutely shocked. Their faces said everything. I think we've gotten too used to seeing influenza trivialized, partially because of COVID, partially because of anti-vaxxers prior to COVID, but many people do suffer or die from flu every year. We can save some of them by being more upfront about the dangers of not vaccinating against flu. Prior to the pandemic, anti-vaxxers also used fear about the flu vaccine to push a bill in my home state that would have banned flu vaccine requirements in healthcare facilities. The thorough discussions around all future vaccines that have been discussed today are eventually going to be stifled by the overtaking of anti-vaccine viewpoints, both on a legislative level and a cultural one. As you all might have seen, the fantastic Dr. Hotez, who researches new vaccines without relying on typical pharmaceutical funding that anti-vaxxers hate so much, has faced attempts at having his innovation stifled by simply calling out the influence of anti-vaccine talking points in our culture. This is my takeaway. We need to be more specific. We need to be specific about what happens when people don't vaccinate. We need to show people examples and videos and feature these people so they know that this is a real potential outcome. And we need more people like Dr. Hotez being specific about why anti-vaccine grifters should not be trusted. I've been following this topic since 2017. If you need help with that, please reach out at 42believer@gmail.com. Thank you for your time.
Thank you for your comment. Our next public speaker is Dr. Kelly Moore.
Good afternoon. I'm Dr. Kelly Moore, the CEO of Immunize.org and a former ACIP member. Immunize.org is a 32-year-old national nonprofit that supports implementation of ACIP recommendations and advocates for health policies that remove barriers to immunization. It's great to be at the threshold of having immunizations recommended to mitigate the undervalued burden of RSV disease in older adults and soon, hopefully, in infants. After today's vote, though, please continue public updates to the ACIP early and often on effectiveness and safety. We need evidence of the impact of these vaccines on the frail elderly in long-term care and elsewhere among the 80-plus population. In addition, as noted, the inflammatory neurologic disease cases observed are for now an uninterpretable signal. Maybe something, maybe not. Either way, confidence in implementation will be helped by regular updates as you learn more. As an aside, it's notable to me that the debate between shared clinical decision-making and routine recommendations seems to weigh more than usual on Medicare logistics and less on the interpretation of efficacy and safety data. And also that today's decision must be made without the final prices. That issue at least seems fixable. After today's votes comes the need to address RSV in infants. We'll have to work fast to make a difference for babies this fall, and I urge the committee and CDC to make decisions concerning maternal vaccination and infant immunization as soon as feasible and to publish an MMWR without delay. Timing is going to be a crunch. In addition, we want affordable infant RSV protection to be within the reach of every family. And to that end, if judged an effective use of resources by ACIP, we encourage you to vote to include the new long-acting monoclonal antibodies, or MABs, in the VFC program so newborns are not denied access due to a family's inability to pay. Thank you to those working to update our regulatory, policymaking, and payment processes to support the use of passive immunization for population health. Experts like Vanderbilt's Jim Crow tell me that long-acting MABs could be the quickest tool to make to protect the population from the next pandemic virus, beating vaccines by months. In light of that, now is a great time to standardize the process to evaluate, approve, and recommend passive immunizations with population-wide application, and to establish the expectation that they, like active vaccinations, should be affordably accessible to all in the interest of public health. Thank you for all your hard work today. I miss you.
Thank you for your comment, Dr. Moore. And with that, our public comment session has concluded. I want to thank our public comment speakers for joining us today, and also thank those who take the time to submit written public comments via the CDC docket as well. At this time, we are going to move on to the vote section of the meeting. Thank you very much for those slides. We will plan to start with a discussion of the motion on the table for RSV adult vaccines. So if we are able to put, thank you. Thank you, team. Okay. The RSV adult vote number 1 up. Before we start the discussion, though, there are a few comments that people have requested to make from earlier, or requests that have come up earlier today. And we just wanted to go through them. So there's 4 related to the RSV session. With regard to questions about CMS, our CMS colleague will be providing a more full update tomorrow during her report, but Dr. Wharton will just provide a really brief comment on that.
We did hear back from Ms. Hansen response to questions the committee had earlier, and that should the RSV older adult vaccine be recommended by ACIP, coverage would be through Part D. And she will be available tomorrow. We did hear from our colleague Mary Beth Hans from CMS regarding questions you all had earlier. Should the older adult RSV vaccine be recommended by ACIP, coverage would be through Part D for Medicare beneficiaries.
Thank you. Next, we'll move on to our industry colleagues. So first, I'll call on Dr. Friedland from GSK. And sorry, the context for this is earlier in the meeting today, there was a request to understand what the cost of these vaccines might be. And so I think Dr. Friedland was going to provide comment on that.
Thank you very much, Dr. Lee. This is Dr. Leonard Friedland from GSK. Thank you for the opportunity to address the committee. We would like to clarify the rationale for the price range reviewed today and respond to ACIP's request for additional information on pricing. The price range reviewed today reflected Arexvy's efficacy over 2 full RSV seasons, which resulted in better cost effectiveness versus our previously submitted analyses. Our original price range was based on clinical data over 1 season only. To aid in the committee's decision-making, we can confirm that the price of our RSV vaccine will fall within a narrowed range of $200 to $295. This reflects the totality of our data reviewed earlier, concluding that Arexvy provides durable efficacy for at least 2 full seasons in the 60 and over population, including in those with underlying comorbidities and across advancing age. This reinforces our confidence in Arexvy's potential to make a significant public health impact. The price of Arexvy will be based on cost effectiveness analyses to ensure efficient allocation of resources. Thank you.
Thank you so much for that clarification. And next, we'll call on our Pfizer colleagues.
Good afternoon. This is Donna Altenpole from Pfizer. As we stated earlier today, to support cost effectiveness analyses as part of the US CDC evidence to recommendation framework, Pfizer has provided to CDC a price range of $180 to $270. We have been consistent with our price range since we first provided our CE analyses early this year. According to the CDC cost effectiveness model shared today, even at the highest end of the Pfizer range, or $270, the Pfizer RSV vaccine would have a cost per quality of under $180,000. Thank you.
Thank you very much for those clarifications. One quick follow-up question. We also have another update.
Yeah,
right?
no, this is a question for Pfizer. Is that a guarantee? Because GSK said they were guaranteed. Is this a guarantee from Pfizer?
It is not a guarantee, as we are in the middle of competitive price negotiations and we have not set our list price.
Thank you. We're going to move on to Dr. Jim Savar, who is, I believe, at CDC and a neurologist, and wanted to provide some follow-up discussion around some of the neurologic issues related to RSV vaccines. Dr. Savar, are you on?
Hi, yeah, sorry, yeah, this is Jim Savar from CDC. Is it possible to have the question repeated? That was the fundamental question.
Dr. Cotton?
Dr. Savar, it's Camille Cotton. My understanding was that you might have some input regarding the neuroinflammatory issues with both of the vaccines.
Yeah, I mean, I guess the one thing that I kind of wanted to speak to specifically was the questions that sort of came up surrounding acute disseminated encephalomyelitis, ADEM. It seemed like there were several ACIP members who were particularly concerned about the report of two possible ADEM cases in the setting of the RSV vaccines. And there also did kind of appear to be an equating of ADEM to in the same sort of category as Guillain-Barré syndrome. I guess the two things that I wanted to just kind of mention were that although they're both inflammatory neurologic diseases, Guillain-Barré syndrome and acute disseminated encephalomyelitis are very different diseases fundamentally. And in particular, although we can see sporadic cases of ADEM in the setting of prior vaccination within that 42-day window, the fundamental association of causality is sometimes hard to establish. The other sort of point about the two cases in question regarding the data that was presented on the RSV vaccines is these were very preliminary diagnoses of acute disseminated encephalomyelitis without the diagnostic testing that we would like, that we as neurologists would like to see to sort of substantiate a diagnosis. Apparently, these two cases were based upon clinical observations only without substantiating neuroimaging or cerebrospinal fluid tests. And it's really difficult, if not impossible, to come at a kind of a definitive diagnosis of acute disseminated encephalomyelitis in the absence of that confirmatory neuroimaging or CSF studies. So those are kind of two issues that I thought were probably worth sort of raising in the context of the RSV discussion to the ACIP members. Over.
Thank you, Dr. Savar, and thank you for joining us. Those were the updates that we had accumulated over today. This vote, the amendment vote number one, as a for those who can recall from this morning, we actually had vote number one, and this is the amendment to vote number one, which we need to vote on first. If this passes, this becomes vote number one. If this does not pass, it goes back to the original vote number one. So just for clarification. Before we proceed, I want to, and by the way, I'm just going to remind folks that we are going to have to get on camera in a moment, but while we're waiting for that, I will ask if there's any additional questions, clarifications needed at this time. I don't see any hands raised, so ACIP members, please turn on your video. I'm going to go around and ask for a vote on amendment number one, which is listed here. Apologies, let me find my video. Thank you. And as a reminder, we're going to ask ACIP members to state your name, whether you have a conflict of interest, and then your vote. After we do this vote, then we'll proceed with the next vote. So I'm going to start with Dr. Lair. Sorry, are you on camera? Video on?
Dr.
Yeah.
Jamie Lair, no conflicts of interest. I'm in favor of this amendment. That's a yes.
Ms. Bata?
Lynn Bata, no conflicts, yes.
Dr. Daly?
Matt Daly, no conflicts, yes.
Ms. McNally?
McNally, no conflicts, yes.
Dr. Sanchez?
Pablo Sanchez, no conflict, yes.
Dr. Long?
Yes. Sarah Long, no conflict, yes.
Thank you. Dr. Cotton?
Camille Cotton, no conflict, no.
Dr. Saneas?
Sybil Saneas, no conflicts, yes.
Dr. Paling?
Kathy Paling, no conflict, yes.
Dr. Bell?
Bell, no conflicts, yes.
Lee, no conflicts, no. Dr. Talbot?
Talbot, no conflicts, no.
Dr. Chen?
Wilbur Chen. Oops. There we go. Wilbur Chen, no conflicts, no.
Dr. Brooks, for vote number 1, please as a reminder, please state your name.
Yeah, Oliver Brooks.
Conflicts?
And no conflicts. I vote yes.
Okay, thank you.
Correction. I'm sorry.
Okay.
This is on the amendment.
This is on the amendment.
Yeah, Oliver Brooks, no comment, no conflicts, no.
Okay, give us a moment to tell it.
Yeah, I just want to confirm this tally to make sure we've got this right. We have yeses from Ms. Bata, Dr. Bell, Dr. Saneas, Dr. Daly, Dr. Lair, Ms. McNally, Dr. Paling, and Dr. Sanchez. Is that correct? And noes from?
How about Sarah Long?
We have
Mine
no.
was yes.
Sarah Long
Was a
says
yes. Okay. And noes from Dr. Brooks, Dr. Chen, Dr. Cotton, Dr. Lee, and Dr. Talbot. Is that correct?
No.
He changed it, which is why I needed to confirm. Okay, so we have a 9-5 vote.
And just to clarify, is this for both vaccines or only for the one that gave us a price?
It's for RSV, adult RSV vaccines, period. Okay, so the amended motion passes, and there is now a recommendation for adults 65 years of age and older may receive a single dose of RSV vaccine using shared clinical decision-making. Thank you. We'll move on to vote number 2. Which is Adults aged 60 to 64 years may receive a single dose of RSV vaccine using shared clinical decision-making. So this time I'm going to start with Dr. Sineas.
Sybil Sinaya's, no conflicts, yes.
Dr. Cotton.
Camille Cotton, no conflicts, yes.
Dr. Long.
Sarah Long, no conflict, yes.
Dr. Sanchez.
Pablo Sanchez, no conflict, yes.
Dr. Brooks.
Oliver Brooks, no conflicts, yes.
Ms. McNally.
McNally, no conflicts, yes.
Dr. Bell.
Bell, no conflicts, yes.
Dr. Daly.
Matt Daly, no conflicts, yes.
Ms. Bata.
Lynn Bata, no conflicts, yes.
Dr. Lear.
Jamie Lair, no conflicts, yes.
Dr. Chen.
Wilbur Chen, no conflict, yes.
Dr. Talbot.
Talbot, no conflict. Sorry, I'm still thinking. Can you come back to me?
I can.
Okay, thank you.
Dr. Paling.
Kathy Paling, no conflict, yes.
Lee, no conflict, yes. Dr. Talbot.
Talbot, no conflict, and I'm going to abstain.
So we have 13 yeses and 1 abstention.
Okay, thank you. And vote number 2 passes. So adults 60 to 64 may receive a single dose of RSV vaccine using shared clinical decision-making. Thank you, everyone. Next, we'll move on to the polio vaccine vote. Before we move on to a vote, let me ask if there's any discussion or conversation that needs to happen around polio vaccine. Questions, clarifications? I see Dr. Kidd in the room, so. I don't see any hands raised. So we'll proceed with a vote. This time I'll start with Dr. Brooks.
Oliver Brooks, no conflicts, yes.
Thank you. Dr. Sanchez?
Sanchez, no conflict, yes.
I'm going to go to Dr. Bell.
Bell, no conflicts, yes.
Dr. Long.
Sarah Long, no conflict, yes.
Dr. Cotton.
Camille Cotton, no conflict, yes.
Dr. Sineas.
Sybil Sinaya's, no conflicts, yes.
Dr. Paling.
Dr. Paling, no conflict, yes.
Lee, no conflicts, yes. Dr. Talbot.
Talbot, no conflicts, yes.
Dr. Chen.
Wilbur Chen, no conflict, yes.
Dr. Lair.
Jamie Lair, no conflicts, yes.
Ms. Bata.
Lynn Bata, no conflicts, yes.
Dr. Daly.
Matt Daly, no conflict, yes.
Ms. McNally.
McNally, no conflicts, yes.
Dr. Wharton.
And it passes 14-0.
Thank you. We'll move on to the next vote for polio. Just going to clarify, are there any questions about vote number 2? Okay, I don't see any hands raised. So adults who have received a primary series of trivalent OPV or IPV in any combination and who are at increased risk of polio exposure may receive another dose of IPV. We will start this time with Ms. Bata.
Lynn Bata, no conflicts, yes.
Thank you, Dr. Daly.
Matt Daly, no conflicts, yes.
Ms. McNally.
McNally, no conflicts, yes.
Dr. Brooks.
Oliver Brooks, no conflicts, yes.
Dr. Sanchez.
Sanchez, no conflict, yes.
Dr. Long.
Long, no, Sarah Long, no conflict, yes.
Dr. Cotton.
Camille Cotton, no conflict, yes.
Dr. Sineas.
Sybil Sineas, no conflict, yes.
Dr. Paling.
Paling, no conflict, yes.
Lee, no conflict, yes. Dr. Talbot.
Talbot, no conflict, yes.
Dr. Chen.
Wilbur Chen, no conflict, yes.
Dr. Lair.
Jamie Lair, no conflicts, yes.
Dr. Bell.
Bell, no conflicts, yes.
Thank you. Dr. Orton.
The motion passes 14-0.
Thank you. We will now move on to the influenza vaccine votes. Okay, influenza vote number 1. Again, I'll just ask, any discussion necessary? Okay. Influenza vaccine vote number 1, all persons aged 6 months or older with egg allergy should receive influenza vaccine, any influenza vaccine, in parentheses, egg-based or non-egg-based, that is otherwise appropriate for the recipient's age and health status can be used. I'm going to start with Dr. Bell.
Bell, no conflicts, yes.
I'm going to skip around, so I'm going to go to Dr. Sanchez next.
Sanchez, no conflict, yes.
Thank you. Dr. Daly.
Daly, no conflicts, yes.
Dr. Cotton.
Camille Cotton, no conflicts, yes.
Dr. Lair.
Lair, no conflicts, yes.
Dr. Paling.
Paling, no conflict, yes.
Thank you. Dr. Talbot.
Talbot, no conflicts, yes.
Dr. Brooks.
Oliver Brooks, no conflict, yes.
That's a yes.
Yes.
Ms. McNally.
McNally, no conflicts, yes.
Dr. Long.
Sarah Long, no conflict, yes.
Ms. Bata.
Bata, no conflicts, yes.
Dr. Sineas.
Sybil Sineas, no conflicts, yes.
Dr. Chen.
Wilbur Chen, no conflicts, yes.
And Lee, no conflicts, yes. Dr. Wharton.
The motion passes 14-0.
Thank you. We'll move on to vote number 2. This is affirming the updated MMWR recommendations and reports listed there on the slide. We'll start with Dr. Bell.
Bell, no conflicts, yes.
Thank you. Dr. Sineas.
Sybil Sineas, no conflicts, yes.
Dr. Chen.
Wilbur Chen, no conflict, yes.
Dr. Sanchez.
Sanchez, no conflict, yes.
Dr. Daly.
Daly, no conflict, yes.
Dr. Brooks.
Brooks, no conflicts, yes.
Ms. McNally.
McNally, no conflicts, yes.
Dr. Long.
Long, no conflict, yes.
Ms. Bata.
Bata, no conflict, yes.
Dr. Cotton.
Camille Cotton, no conflicts, yes.
Dr. Lair.
Jamie Lair, no conflict, yes.
Dr. Paling.
Paling, no conflict, yes.
Dr. Talbot.
Talbot, no conflicts, yes.
Lee, no conflicts, yes. Dr. Wharton.
The motion passes 14-0.
Thank you. And I think we are at our final vote of the day, the VFC vote for influenza vaccines, to approve the VFC resolution for influenza vaccines. So I'm going to start again with Dr. Bell.
Bell, no conflicts, yes.
Lee, no conflicts, yes. Dr. Paling.
Paling, no conflict, yes.
Dr. Talbot.
Talbot, no conflicts, yes.
Dr. Chen.
Chen, no conflict, yes.
Dr. Sineas.
Sybil Sinaus, no conflicts, yes.
Dr. Cotton.
Camille Cotton, no conflicts, yes.
Dr. Lair.
Jamie Lair, no conflicts, yes.
Ms. Bata.
Bata, no conflicts, yes.
Dr. Long.
Sarah Long, no conflict, yes.
Dr. Sanchez.
Sanchez, no conflict, yes.
Dr. Daly.
Matt Daly, no conflict, yes.
Ms. McNally.
McNally, no conflicts, yes.
Dr. Brooks.
Brooks, no conflicts, yes.
Dr. Wharton.
And the VFC resolution passes 14-0.
Thank you, everyone. I believe that concludes our day one of our ACIP meeting. Thank you, everyone, for your work today. It's very much appreciated. We'll be convening again tomorrow, I believe, at 8 a.m. So we look forward to seeing you then. Today's meeting is now adjourned.